I just admitted a few more people from the waiting room, so they should be logged in. So I'll go ahead and hand it over to you, Ron. It's
Okay.
nice to meet you guys virtually.
Yeah, you too, and welcome. You got some big shoes to fill, as you know, with Charlie, but
Yes, I do. Very much so.
looks like we have 4 members on here, unless Matt and Mr. Almeida have joined. But anyway, we do have a quorum. So call the meeting to order, and also it's not on the agenda because that's my fault. But sent out the minutes from the past meeting whenever I received them from Charlie. So if anybody has any changes to make, if not, then motion to approve. I need a motion to approve the minutes from the last meeting.
I'll make that motion, Ron.
Okay, thanks. Motion by Rosemary. Need a second.
Second.
Second by Paula. All those in favor say aye.
Aye.
Any opposed? Okay. Paula, I know you had the first 3 here. So if you want, I'll just take them one by one here and turn it over to you. But
Sure.
The OTC list, I mean, and you're referring to the document that came out from Medicaid, but anyway, I'll just let you take over from there.
Okay. Yes. There is an OTC list for the managed care organizations on the Med Impact portal. Can everyone hear me?
Yes.
Okay, great. And then on page 11, at the bottom of the page, it just lists skin protectants. And I've had several providers reach out to me asking if there can be some examples given in that section around the emollient creams, the gels, the kits, the liquids, so that providers know exactly what is preferred, so they know what medications to prescribe for the OTC products in this category.
And what would you, I guess, what would be your ask of the MAC is to
ask DMS or Med Impact to provide some example products that are covered on the OTC list for this skin protectant category.
Okay. And do you want to make that into a motion?
I do.
Okay. Motion by Paula.
Second.
Second by Meredith. Any further discussion? All those in favor say aye.
Aye.
And any opposed? Okay. And I'll work with you, Aaron, on getting you all these motions afterwards. And
Thank you.
okay, and then the second one, can additional OTC products be added? I can make comments just real quick that obviously I've said it before, and it kind of goes into the third one there too. But anyway, I have a great deal of autism patients that obviously are deficient in metabolic pathway enzymes or elements, and they could really benefit from, you know, glutathione, taurine, magnesium, zinc, and the essential fatty acids just as a baseline. So, you know, I just wish that we could help these parents out by having these covered, because many of them cannot afford the items that the child needs. But anyway, go ahead, Paula, with your comments.
I've met with several providers over the last, 2 to 3 months, and a lot of them were pediatric providers. And they just gave me a list of a few items that they feel like should be added to the formulary. And I've listed them, the generic Electro liquid. The zinc oxide 20% is on the OTC coverage list, but have had several providers ask about the 40%. And then melatonin is covered, but there's no melatonin gummies for those older kids that may have trouble swallowing. And then I've had a lot of discussion from providers around the Novaferrum. Excuse me. I know it's a branded product, but several providers have said the products that are listed on the preferred drug list don't taste well, and their patients will not take them. So it's kind of useless for them to prescribe them. So a recommendation was made to see if Novaferrum could be added.
If you don't care, I would like to include the ones that I mentioned
Absolutely.
in your motion.
Yes.
So if you want to make that motion.
I have a motion to see if EMS and MedImpact can review the OTC preferred drug list to add some potential additional agents, including the metabolic agents, the generic Electro liquid, the zinc oxide 40%, the melatonin gummies, and Novaferrum.
Ron, this is Fatima with Medicaid. If I could just jump in here. I will say that, we are going under an OTC revamp in general. We're taking a look at all the products. We're taking a look at things, that folks are recommending to add. So we'll certainly take this back. If you can provide all the specific products that you're making a recommendation on, that'll make things easier for us when we review them. And then we can provide a response about the decision when it's time.
Okay, thank you. Okay, got a motion by Paula,
Yes.
I have a second.
I'll second that motion.
Okay, second by Rosemary. Any further discussion? Okay, all in favor, say aye.
Aye.
And any,
Aye.
okay, and then any opposed? Okay, Paula, do you want to just brush
Yeah.
on item 3 there?
Yeah, sorry. I've again had several provider meetings over the last several weeks, and I had a pediatric provider. She had a long discussion. I know, Ron, I sent you several studies that she forwarded to me. She just feels like she would like to ask DMS to review the eczema category at the next P&T or future P&Ts for additional product considerations. She gave me an example, this last provider did, of CeraVive. She actually got specific NDCs for the products that are listed on the preferred list. And she's actually giving that paperwork out to her patients with the prescriptions. And she's still getting feedback from the chain pharmacies that CeraVive is not covered. So she definitely would like DMS to review that category and any other additional topical categories for eczema, because she feels like that this class needs a review.
Okay,
Paula, if there are certain NDCs that are not, processing at the pharmacy, just make sure you reach out to either DMS or MedImpact so that we can research.
And I have, and MedImpact is telling me that they're processing, but I'm getting mixed messaging from pharmacies. Some tell me they're using the UPC, that the UPC code is what's listed versus the NDC, which doesn't make sense to me because I know it has to be an NDC. So I can send that to MedImpact again and maybe CC you on it, Fatima.
Yeah, that sounds good.
and on this, Paula, can you?
Okay, great. Thank you.
Can you list the products that this pediatrician and different ones have asked you about, so we can?
Well, she didn't really give me, and some of the others didn't give me any specific drugs. They just feel like that
It
the
just needs-
category needs a review.
Okay.
And she did ask, and I'm pretty sure I know the answer to this, that there is a pediatric provider on the P&T, and I know there is. But she did ask me that question, and I said, "Oh, I'm sure that there is one." But she did ask me that as well because she feels like there just isn't adequate coverage for topical. She's constantly getting rejections from pharmacies around this category for this indication.
Okay. So your motion is to review this category.
Class, yes, this class, yes.
Okay. Got a motion.
And if you do need some additional insight, DMS, I can get some if you want some additional products or for review or whatever from the pediatric providers that I work with. I'd be happy to send you a list of possible additions to this class. They're more than willing to do that.
Yes, that would be helpful for us. Thank you.
Okay, I can get you a list.
Okay. Got a motion from Paula.
Yes. To review the eczema topical class for additional consideration in next or future P&T.
I'll second that.
Problems from doing this at home. Do I have a second on that?
I said I would second that, Ron, it's Meredith.
Okay, all right. Got a first by Paula, second by Meredith. Any further discussion? All those in favor say aye.
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 Any opposed? Okay. And then number 4, Matt, if you want to take over so I can mute out my dog barking.
Sure. I've experienced since Med Impact came on, as I'm sure everyone else has, a big increase in the amount of cash prescriptions we've had for opiates, for me specifically hydrocodone and benzos. And I know some patients are getting them covered, and I've asked prescribers, what are you doing to get that covered? And they're coming up with, I don't really know. The ones that are getting covered are the same diagnosis codes as the ones that we are getting rejections on PAs. And not only is it difficult for patients to afford these medications on a monthly basis, but with the settlement that the big 3 wholesalers have done, they're looking at people's cash prescriptions for controls. And even though there's a legitimate reason for it, Medicaid's not covering it, people like me that are in high Medicaid areas, I mean, I've seen my hydrocodone's cash percentage quadruple, same with my benzos. And I like to be able to help the patients and help make other pharmacies cash prescriptions for controlled substances look better. And everyone I've spoke to in the area that I've worked, pharmacy wise, they're having the same issue of no one's getting it covered. It's difficult. And I feel like this is going to be a problem for a lot of people. Not only that, but the patients are having difficulties affording their medications. So I didn't know if there might be some insight, a tutorial or something we can help doctors get this covered correctly for patients and the pharmacies. I'm not really sure what to tell them. I don't see what kind of happens on the doctors and the PAs, but every office I've called has kind of had the same response. Things that are going through are also the same ones that are getting rejected. We don't know what to do.
Yeah, so I can chime in there.
And just to elaborate a little bit, Fatima, on this, pharmacies are being dropped by their wholesalers, which is a traumatic experience because they're, first of all, they just had the big settlement, the big 3 just had the big settlement with DEA. So if you go over that threshold of percentage of cash controlled substances filled, they're just dropping people. And then good luck in trying to get another wholesaler after you've been dropped. So this isn't just a minor issue. This is a major issue, and it's only getting worse. I've had one of my pharmacies called, that the DEA called and said, you normally order one bottle of Tylenol, generic Tylenol 3 a month. Why'd you have to order 2? And, the answer is because obviously this dentist in the area picked up just doing Tylenol 3 instead of hydrocodone. But that's how much we're being scrutinized on a daily level of what we're ordering. And my ordering patterns haven't changed for years, but the scrutiny certainly has gone up. And when you're sitting there, just you got a patient needs a drug, you order the drug in, it's not that simple anymore, because of the pressure that DEA has put on everybody. And when you look at pharmacies that have been out there for years, taking care of patients, and now they're being dropped, it to me, and really there's not an easy solution to fix their issue, because they're marked after that, and they're just legitimate pharmacies trying to take care of the prescriptions. So I don't know if you knew that or not, Fatima, that there was people out there having issues with the DEA.
I did not, Ron, so thank you for shedding light on that situation. With regards to, PAs for opiates and benzos, doctors have resources with MedImpact to reach out and to help, get those prior authorizations approved and understand the rationale as to why something was denied. In addition, a lot of prior auths are electronic PAs, so providers can use Cover My Meds, to make that process simpler. We also put out forms, opioid and benzo specific forms on our website, or on the MedImpact website rather, that are a little more targeted and easier for prescribers to fill out and send back to MedImpact, to kind of streamline the process that PAs require. And, if there are issues getting prior auths approved, we're happy to take a look at it with DMS, research it internally, work with MedImpact to meet the needs of our members.
Is there anything pharmacies can do to help get a PA approved? Or is it just the doctor's offices?
Well, it depends. If the rejection that the pharmacy is receiving is that 75 PA required, that would require collaboration with the doctor's office to fill out the prior authorization appropriately, meet the criteria. Our PA criteria, especially for opioids and benzos, is laid out on our website. That criteria is very transparent for doctors, for pharmacies. And there are some things that go through via smart PA. So you might not realize that from a pharmacist perspective, you might not realize that there is a prior auth that's going on in the back end. And then if that criteria is not being met, then that's when it would deny for one patient versus another.
Are you getting a lot of prescribers successfully getting PAs, or do you not see that information? Or because I can't find anyone that's good at it. Everyone says it's kind of a crapshoot at the moment.
In what way? In terms of submitting the PA or
getting successful PAs?
So, I think that requires review of the criteria prior to submitting the PA. So if you take a look at the PA criteria, see what exactly is needed, ensure that the member meets that criteria for the requested drug. There really should not be issues, but again, if there are, there is a MedImpact clinical line that can help. You can always reach out to DMS, myself. MedImpact has a general mailbox where they take provider concerns. So those avenues are available.
Okay, I will look those up and report back if I have any issues.
Sure, and I can put some of that in the chat to make your life easier.
That would be great. Thank you.
Okay. Moving on then to item number 5. And Fatima and I have had emails going back and forth. I know KPHA has weighed in on this issue. The Kentucky Retail Federation lobbyists has weighed in on this issue. The fact of the matter is there's one wholesaler out there that has a product that Med Impact is basing their reimbursement off of. And not everybody can deal with this one wholesaler, this secondary wholesaler. And it is also a patient non-preferred product, meaning the patients do not like that they claim that it does not work for them. Because it took me a while to even find this product out there that was so dirt cheap, that's the reason why the reimbursement level had gone down so much, or really since Med Impact took over. But basically, in just reviewing the first 6 months of last year and the last 6 months, we were getting reimbursed at an adequate rate on the ingredient cost paid. And in the latter 6 months, we were not. And then somebody else can weigh in on this, because, you know, it's one thing that I look at the 23-day threshold, and yeah, beforehand, we wasn't saying anything about it because, hey, we were getting reimbursed good on the ingredient cost paid because we weren't getting much of a dispensing fee in the first place. But obviously now when you look at the reimbursement, and, you know, we go through just this one strength, 2 pharmacies that are closest to this clinic that went from 7 clinics into 1. We go through 9,000 tablets a month of just this particular strength of generic Suboxone H/2. So obviously it's a big hit for us when we get reimbursed below cost on our reimbursement. And then because the doctors have a particular NDC they want, because they hear from their patients that they like this one NDC that tastes good, because it is a dissolved sublingual tablet. So I don't have much of a decision in, well, I'm going to get that dirt cheap one that nobody wants to use. And the doctors, when they write for a specific NDC and says do not sub, you don't have much of a choice. So that's on the ingredient cost paid side. And then of course we still have the issue of 88% of my Suboxone claims are on a 7-day cycle. There are some that are able to graduate up and go to 14-day or even 21-day cycle. I think we even have a couple that are at 28-day. But anyway, that's just the nature of that therapy. And I really would like to invite anybody else on the committee here to weigh in on what they're seeing.
I'm seeing an increase of patient base due to the Suboxone, you know, trying to fix the opioid epidemic, and it's an increase of prescriptions, and it's after your dispensing fee for that first week of the month, you're for the most part filling prescriptions for free, or losing after you take into account the cost to receive an e-scribe, submit the claim, someone to fill it, check it, and your materials. So I want to continue to help this epidemic, but at what cost?
And that's the problem that we've got, is that, you know, where there are 2 main pharmacies, and I've had, you know, multiple conversations with the clinic itself, and their feedback is, we are not going to tell our doctors how to prescribe. So we just got to pretty well live with it. And that's the problem that I have. And it took me, when a pharmacy closed in October, obviously our threshold demand went up. Again, another DEA issue, to where it took me 3 months to get the threshold up to where I wasn't cut off at both of those stores, say on the 25th of the month, in ordering them. So again, there was an access issue at that point. So anyway, Fatima, I didn't know if you wanted to weigh in any more on this, to fill everybody else in, or.
So, the fee for service methodology is the 1064 every 23 days. And, that's what we followed with the implementation of the single PBM. I apologize, I'm a little sick today. So that's the fee for service methodology. And, we're approaching the 1 year mark with Med Impact. So, we're looking at different dispense fee approaches that other states have in place. And, that's a conversation that will happen with leadership in the next few months as we approach that 1 year mark. And, with regards to the ingredient cost, which I believe I've mentioned in some emails, that piece of it is a little different between the two methodologies that were utilized with the MCOs and fee for service. So, if you take a look at the dispense fee, solely the dispense fee between pre 7-1 and post 7-1, the MCOs were giving you guys $2 to $3 per dispensation, and now it's that 1064. So the dispense fee essentially aligns itself from a dispense fee perspective. Again, the ingredient cost, I think, is a different conversation. The MCOs had a different reimbursement methodology, and now we're going with the fee for service methodology, which was clearly stated as NADAC, MAC, WAC, FUL, and UNC.
Okay.
So
Again, go ahead.
This is Joe Lenard. I got a quick question. Is this a MAC issue or is this a NADAC issue that you're talking about, Ron, on the ingredient cost side?
It's a
NADAC.
NADAC.
I got a question. It's a NADAC.
Yeah.
So what's happening is, what you're saying is, when NADAC, when this generic came into the market really low, at a low price, it drove down the average cost across the other. And so, okay.
And
I
it's
see what you're saying.
it's not preferred by patients. It's not preferred by
Yeah.
prescribers because of the patient feedback. So,
Yeah. Okay. Thank you.
thanks, Joe.
You bet.
And as far as my percentage of 7-day, looking at just the therapy that we see, 88%, and that can vary from month to month. But this last month, it was 88% are on a 7-day cycle, and it's going to continue on those people until they can graduate up. Obviously that shows you where the disparity is in our, just arguing between, this is one of those products I wish that we could get a waiver on, to waive the 23-day, because of what this, what Matt, conveyed a while ago about how it's just at a break even or a loss on every single one of those. So it's a lot of labor and a lot of knowledge base working with these patients, because as I've stated before, of how much extra time and effort it goes through, many times I'm calling the physicians to discuss their therapy because of issues. So anyway, anybody else have anything to add on that topic?
Ron, I'd just like to add, from KIPA standpoint, our independents, across the state, that this is definitely a major issue. It's not just isolated, to a couple of different areas. It is across the state. And I think we brought this up numerous times about the pricing and also about the 23-day, this one dispensing fee every 23 days. So we're in total agreement with you and Matt on this from a KIPA standpoint.
Okay, thank you.
Yeah, I think the other thing to point out, which I think you are, is that, unlike any other drug, this 7-day isn't necessarily a choice. It's not just that's what they feel like they need to do. This is a legal requirement. And like you said, they can't graduate up, to more day supply until they meet certain criteria. So that's what makes this drug very different from anything else, that they're just choosing to reevaluate. They don't really have that choice. They have to. And if, they're going to have to reevaluate and we're going to have to dispense it, then I think there should be compensation for the work that's being done.
Okay. Thank you, Meredith. Thank you, Rosemary.
Well, I'll also add, I mean, for independent providers, or even, not any provider that's prescribing it, they have no incentive to not write 7 days. I mean, they're able to bill for visits every week. So they're not really incentivized to write for more than 7 days, which really falls on us to, take the financial brunt of it.
And a lot of that, Matt, is laid out in their guidelines too. So, I mean, I even have some of them that they'll write for just a 2 or 3 days because they have to do their interview with the patient to evaluate their addiction. So it's their addiction interview that they have to get within a 7-day period. So a lot of times there's even 2 dispensings within 7 days. So it's just a different therapy altogether for this this group of patients. So, okay. Any further comments? Okay, that's all we had on the agenda today. So thanks everybody for attending. Aaron, I'll get you all the motions and the comments for the next meeting. I think it's May 26th, the next MAC meeting. I may be wrong. I know it's in May.
You're correct.
Okay. All right. Thank you all. Have a good day.
Thanks, Ron.
Thanks, everybody. Have a great afternoon.
Thanks.